Hi, my name is Sharon Cresci. I am a cardiologist and geneticist at Washington University School of Medicine in St. Louis, and I am vice chair of this statement.
Hi, my name's Naveen Pereira. I'm a cardiologist at the Mayo Clinic in Rochester. I'm professor of medicine and associate professor of pharmacology. I'm chair of clinical trials operations at Mayo Clinic, and I'm the chair of the scientific statement that is titled CYP2C19, Genetic Testing for Oral P2Y12 Inhibitor Therapy.
We felt that there was a gap in conveying the recent medical knowledge, and so we wanted to comprehensively and yet concisely convey this in a scientific statement for the American Heart Association.
So we decided to write this statement because a lot of data has been published recently about this topic and whether we should do genetic testing for oral P2Y12 inhibitor therapy. And this recent data has not been incorporated and interpreted for all the recent guidelines that have been published. So given this new data, we felt that we needed to compile it and present it in an understandable way and interpret it appropriately for the clinician. So we know that there are a substantial number of individuals who have a loss of function in this enzyme that metabolizes clopidogrel and is important to convert clopidogrel to an active drug. And these individuals, when treated with clopidogrel, are at a very high risk for ischemic events. And data now that has been published over the past decade, and most recently randomized clinical trials and meta-analyses that we have reviewed for the scientific statement, suggests that CYP2C19 genetic testing could be beneficial for guiding oral P2Y12 inhibitor therapy for patients with acute coronary syndromes and or those who undergo percutaneous coronary intervention.
In addition to that major takeaway, I think an additional takeaway is that there are significant barriers that may need to be overcome before universal implementation of this genetic testing, and yet we have identified potential opportunities to overcome those barriers in this statement. The most contemporaneous cost-effective analysis showed that it was cost-effective. They used current pricing, and they used the VA, so actual pricing from the VA and actual event rates from the VA to make their analysis. And we discussed that particular cost-effective analysis in this statement.
So CYP2C19 is a drug metabolizing enzyme that's present in the liver, and it belongs to these group of enzymes that are known as cytochrome P450. It metabolizes not only clopidogrel, but other important drugs.
And one thing that's important is that, and it's a little confusing, is that the gene that encodes that protein is also called CYP2C19. And so the name of the gene is the same as the name of the enzyme.
So Sharon, this was a very interesting AHA scientific statement. There were a lot of guidelines recently published on antiplatelet therapy, coronary artery disease. However, genetic testing was not addressed directly, especially for CYP2C19 to guide antiplatelet therapy. So this scientific statement, I think, is timely and it's relevant. But before we go into the details of the content of the scientific statement, I think it's important for the audience to understand a little background. And so clopidogrel is one of the most widely prescribed P2Y12 inhibitors. It's used in a range of disease processes, coronary artery disease and stroke. And we know that clopidogrel is a prodrug. And basically, it has to be biotransformed to an active metabolite. And it is the active metabolite that actually acts on the P2Y12 receptor and prevents platelet aggregation. And one of the major drivers of that biotransformation is CYP2C19. This is an enzyme that metabolizes multiple drugs, and it's present in the liver. It's a hepatic P450 cytochrome enzyme. And we know that there are individuals who basically have genetic variation which prevents them from having appropriate function of the enzyme, CYP2C19. The enzyme doesn't work well in these individuals, and so the inactive clopidogrel drug does not get converted to the active metabolite. So in effect, there are individuals who have less drug when they're taking clopidogrel. Sharon, how common is this problem?
Yeah, so I think it's really important. 1 in 3 people may have that ability to metabolize, and it actually varies between different populations. So if you have different ancestry, such as Asian ancestry or African ancestry, it may be even more relevant. So it's a very important problem, and I think our statement really covered the analysis and comprehensively talked about the data that there is behind this.
So overall summary is that when loss of function patients for CYP2C19 are treated with clopidogrel, they're at high risk for events. But when they're treated with ticagrelor or prasugrel, they have less events. And this kind of lays the background for we should identify these patients. And by events, I mean less ischemic events. If you did genetic guided therapy and you compared it to clopidogrel, a pre-specified analysis of a large trial showed that genetic guided therapy results in lesser ischemic events. So now the problem is, why aren't we implementing this practice? Sharon, any thoughts about that?
Yeah, and I think we do address this in the statement as well. There are several issues. One is whether or not this strategy is cost effective. And then the other aspect of our statement that I think is very valuable to clinicians and to policymakers is we discuss issues and hurdles to implementation of genetic, to knowing what the person's genetic makeup is before potentially you would start clopidogrel. And so how do you get that into the chart in a way that's easily accessible to all physicians? And what are the barriers that need to be overcome? And so I think we really have addressed comprehensively all issues around this subject.
And practitioners worry, is it covered by insurance? One of the advantages of genetic testing we've seen in our careers is the cost has dramatically gone down for genetic testing, both at the research level and at a commercial level. Pharmacogenetic testing has considerably decreased. So I guess that has favored the cost-effective analyses.
And actually, with respect to certain insurance payers and Medicare, there's even better coverage of panels of genetic testing. And so I think that might be the wave of the future, is that people will be getting larger panels that are paid for, for different indications.
So Sharon, I think we've really summarized state-of-the-art literature, provided a great update and a summary. We'll have 10 takeaway points.
Yeah.
So the busy practitioner doesn't have time to read the whole statement, but can if they want to, and they can refer to the studies. Hopefully, we've created a statement, written a statement that would be helpful and in guiding practice and helpful perhaps in developing guidelines as to what to do, because ultimately guidelines will result in a recommendation for practice.
Sure. And I do think that we have really tried to concisely summarize the important points. And so I agree. I think it would not be tough to read the whole statement, because it's very directed and very clinically relevant.
I think we had a lot of fun writing the scientific statement. We had wide representation from the different councils of the American Heart Association. We had rigorous review, which went on for many, many months. And we are really pleased to provide you all with this summary and the scientific statement. I hope you find it as useful and fun to read as we had fun writing it. Thank you very much for your attention.
Thank you.